but my name is Sharon Byun. I'm a board certified OBGYN and lifestyle medicine physician. I'm also a Menopause Society certified practitioner and have additional certification in nutrition science from the Stanford Center for Health Education. So I'm going to be talking about hormone therapy. And so there are three main categories of FDA approved indications for hormone therapy. Hormone therapy is first-line treatment for the treatment of hot flashes and night sweats, or so-called vasomotor symptoms, as well as for the treatment of genitourinary syndrome of menopause, which includes a constellation of symptoms and conditions: vaginal dryness, painful intercourse, urinary frequency, and recurrent urinary tract infections. Hormone therapy is also FDA approved for the prevention of osteoporosis, but not for the treatment of osteoporosis. But as Dr. Young mentioned, there are many other symptoms associated with perimenopause and postmenopause for which hormone therapy can be helpful. And there's actually a validated menopause symptom scoring system using a variety of symptoms that you can rate on a scale of not having the symptoms at all to having symptoms that vary in degrees of severity from mild, moderate, or severe. And then depending on the number and degree of severity, a composite score is calculated such that if it's greater than 15, it would suggest estrogen deficiency for which hormone therapy may be beneficial. And it's not uncommon for women to have scores in the range of 20 to 50. And then with adequate treatment tailored to your individual needs, your score can decrease to less than 10 in 3 to 6 months. So for most women who are under the age of 60 or within 10 years of menopause with no contraindications, hormone therapy is a safe and reasonable option. So does this mean that you're not a candidate for hormone therapy if you've not yet gone through menopause, or if you're over the age of 60 or more than 10 years out from menopause? Well, it depends, but the sad reality is currently fewer than 5% of women who are candidates for hormone therapy are prescribed it. So why are so few women offered or prescribed hormone therapy? Well, a lot of the reasons stem from the backlash of the Women's Health Initiative study, which was published back in 2002. And I was a resident at this time, and all of a sudden we stopped prescribing hormone therapy for women because the study was inappropriately linking risks of hormone therapy to perimenopausal and recently menopausal women that actually didn't, in fact, exist. So, what we do know now in recent years, after ongoing follow up and further critical appraisal of the WHI and other studies looking at safety and long term effects of hormone therapy, we have come to realize that hormone therapy is quite safe and beneficial for most women. So, for women who are perimenopausal, we do want to know what your symptoms are. And do we think that they're related to estrogen deficiency? And that's where that symptom scoring system can come into play and be helpful. Also, do you need to be on birth control? Because hormone therapy is not a form of contraception. And if you have not yet transitioned into menopause, we need to make sure that you don't have an unintended pregnancy. So these are some of the issues we need to consider. And I will say that I hear from many women in their 40s who are not yet postmenopausal that they often feel dismissed when discussing their symptoms and are told that they're too young to need hormone therapy, which is just not the case. For older women, we do worry about heart disease as women get older and whether taking hormone therapy may increase the risk of heart attack and stroke, as well as increase the risk of dementia. So if you started hormone therapy at a younger age and are doing well with no existing heart disease, you likely can continue taking hormone therapy safely beyond the age of 60. However, if you've never taken hormone therapy before and now you're over the age of 60 or farther removed from menopause, it's going to depend on your symptoms, your current medical and past conditions that will help guide recommendations and determine whether or not it's a safe option for you. The breast cancer is always a big question that comes up, and it's linked to hormones and whether or not that increases your risk. As you may know, breast cancer is the most common cancer among women, followed by lung and colon. Statistically, 12.5% or 1 in 8 women will develop breast cancer in their lifetime. And the average age for diagnosis is around the age of 62. So factors that affect breast cancer risk include things like family history, whether or not you've had an abnormal mammogram or a breast biopsy, the age at your first menstrual period and age at menopause, the age at which you had your first child, whether or not you breastfed, and whether or not you're obese. So going back to the Women's Health Initiative study, it did show that for women who were at an average age of 63 at the start of the study, so older than perimenopause and recently menopausal, for those women who took a specific combination and dose of an estrogen and progestin medication called Prempro, they found an increased incidence of breast cancer of 8 more cases per 10,000 women for women who took that medication for more than 5 years compared to women who took placebo. For women who had had a hysterectomy and only took estrogen, they actually had a decreased incidence of breast cancer. Is this confusing? Yes, it is. And there's a lot that we don't quite understand about the role of estrogen and progesterone with breast cancer. For one, if estrogen causes breast cancer, why would we see an increase in the incidence of breast cancer after menopause when estrogen levels in women are low? And why did women who took estrogen only in the Women's Health Initiative have a lower incidence of breast cancer compared to women who did not take estrogen? So, should we worry about breast cancer? Yes, of course. But the reality is that heart disease is far and away the number one killer of women and men than all cancers combined. So I don't intend to minimize the concern over breast cancer by any means, but this is where an assessment of breast cancer risk needs to be taken into account, balanced by the symptoms and quality of life, as well as heart disease risk and other factors. And after decades of additional research and review of scientific literature, the reality is that hormones, and specifically estrogen alone, does not appear to increase breast cancer risk. So there are contraindications to taking hormone therapy. One would be undiagnosed abnormal genital bleeding. So if you're a woman over the age of 45 with abnormal uterine bleeding, you should have an evaluation before starting hormone therapy. This is another area of confusion, I know, because so many women in their 40s start to have irregular periods. So your doctor or healthcare provider needs to take a good menstrual cycle history to determine if your cycles may just be, this is my normal perimenopausal cycle, or if it's really something abnormal that needs to be evaluated. If you're younger than the age of 45, you also may need an evaluation for abnormal bleeding, especially if you have risk factors for uterine cancer, such as obesity. And certainly, if you're postmenopausal with bleeding, this definitely needs to be evaluated prior to starting hormone therapy with either a biopsy or an ultrasound or both. Um, so for breast cancer, again, there's an asterisk next to this because there's some debate as to whether or not a woman with a history of breast cancer can safely take hormone therapy. At the very least, vaginal estrogen to treat vaginal dryness, painful intercourse, and urinary symptoms can be an option, and this option should be discussed together with a menopause specialist and a women's oncologist. As for other estrogen dependent cancers like endometrial cancer, because it's associated with estrogen, estrogen containing hormone therapy should be avoided, but progesterone can be an option for these women. And then, as far as people with a history of a blood clot, the concern here is that estrogen does increase the risk of having a blood clot. However, not all blood clots are the same in terms of how they occur. Some may be due to a genetic predisposition, and some may be due to circumstances such as in the setting of prolonged immobilization. So, believe it or not, there are actually certain cases where even somebody who's had a blood clot may be a candidate for hormone therapy. Again, this is where there needs to be discussion about risk and benefits of hormone therapy and also alternative treatment options. And it really requires an understanding of what your symptoms are and what the realistic expectations and goals of treatment are. So, for hormone therapy risks and benefits, again, for most women who are under the age of 60 or within 10 years of menopause who have no contraindications, the benefits of hormone therapy tend to outweigh the risks. And these benefits include, of course, lessening hot flushes and night sweats, which can lead to improved sleep quality, decreased irritability, and brain fog. The benefits include improving vaginal dryness and painful intercourse, improving urinary symptoms and reducing recurrent urinary tract infections, improving bone density, and possibly lowering the risk of heart disease and type 2 diabetes. Um, as for the risks, there can be an increased risk of heart attack and stroke in older women and an increased risk of having a blood clot, although the absolute risk of having a blood clot is low. Transdermal or through the skin estrogen does have a lower risk compared to pills, so that may factor into decision making. And again, the breast cancer risk remains a source of confusion. However, the Menopause Society statement still cautions about possible increased risk of breast cancer with prolonged hormone therapy use. So, for types of hormone therapy, there are four main ways in which we prescribe hormone therapy. We can prescribe estrogen only if you don't have a uterus. We can prescribe estrogen plus progestogen or estrogen plus an estrogen receptor agonist antagonist or ERAA if you have a uterus. Or we can prescribe progesterone alone if you can't take estrogen. So if you have a uterus, you must take a progestogen or ERAA because estrogen stimulates the lining of the uterus to grow. And if you don't take a progestogen or ERAA to balance out the estrogen effect, it could increase your risk of getting cancer of the uterus. So I know that sounds scary, but taking a combination of these medications makes it a very safe way of taking hormone therapy. So ERAA blocks the effect of estrogen on the lining of the uterus, and it's an alternative to taking progestogen. Some women are sensitive to progestogen hormones. For some women, it does cause adverse mood changes or bloating that's not tolerable. And so they want an alternative to that type of medication. Again, if you don't have a uterus, you can just take estrogen alone, but you actually still can take a progesterone, which some people choose to do because it can help them with their sleep at night. And then lastly, as I said, some women who can't take estrogen do have improvement in menopause symptoms just by taking progesterone alone. So if we look at estrogen only hormones, there are three ways that you can get this medication. One would be by taking an oral pill. A second way would be by placing the medication in the vagina. And a third way would be placing the medication on the skin. There is only one form of vaginal estrogen that's systemic, which means that it can treat hot flashes and night sweats and help with bone density, in addition to symptoms of vaginal dryness and other genitourinary symptoms. And that form of vaginal estrogen is a ring called femring that's inserted into the vagina for 90 days. The rest of the vaginal estrogen treatment options are used to treat vaginal dryness and other genitourinary symptoms only. If you need to take both estrogen and a progestogen, you can take a combination pill or use a combination patch, or you can take a separate estrogen and progestogen pill, or you can use a separate estrogen patch and take an oral estrogen pill. So the decision to use a pill form versus a patch versus a vaginal option is partly based on personal preference, but then there are some pros and cons of the different options. So for oral pills, for most people, it's a familiar way to take medication. As I mentioned earlier, you can take a separate estrogen and progesterone pill, or you can do a combination pill. For people who are accustomed to taking birth control pills, it's not that different from that method. However, compared to the transdermal route of taking hormones, oral pills may potentially increase the risk of blood clot compared to the skin option. But on the plus side, it can potentially help improve your good cholesterol, your HDL, and improve your bad cholesterol, which is your LDL. At the same time, it can worsen your triglycerides, your C-reactive protein, and increase the risk of gallstones, and can also potentially decrease your libido compared to the skin option. For the transdermal or skin option, for some people, but not most, I would say, they do have a reaction to the adhesive that can cause skin irritation. It does require for you to remember to change a patch twice weekly. And for some people that are just very sweaty or in water a lot, they have trouble with the adhesive staying on and the patch falls off. But I find that for most people, changing the patch twice a week, this is not an issue. Again, you can use an estrogen patch and take a separate oral progesterone pill, or there are patch formulations that come with a combination of estrogen and progesterone. And then lastly, for the vaginal option, it is convenient. You change it every 90 days. However, currently there's no generic option. There's only Femring, which is expensive. And because it's an estrogen only ring, you do need to take a progestogen if you have a uterus. So, moving on to progesterone only medication. This has different routes of delivery as well. Um, you can take the medication as a pill, and this option is preferred to help with sleep, specifically oral progesterone taken at bedtime. The Mirena IUD or other progestin IUDs are great options if you still need birth control or have side effects from oral progesterone. And you can still take oral progesterone for sleep in addition to an IUD if needed. Um, Vaginal progesterone, I will say, is quite expensive. This form of progesterone is more commonly used for infertility treatment than for menopausal hormone therapy, but I just have it up here for completeness. And lastly, I just want to point out that progesterone is not well absorbed through the skin, so transdermal form is not recommended. So, just a word on oral estrogen and ERAA, since most people are less familiar with this option. It was FDA approved in October of 2013 for the treatment of moderate to severe hot flashes and night sweats and prevention of osteoporosis in postmenopausal women with a uterus. The trade name is Duavie, and it is currently quite expensive without a generic option. But again, it's an alternative for women who can't tolerate progesterone and need it. Okay, so what should you take? Well, if you can't take hormones, Dr. Coleman is going to be speaking in a moment about alternatives to hormone therapy. As I said, if you have a uterus, you have to take estrogen with either progestogen or ERAA. And if you don't have a uterus, you can take estrogen only, but some women will still take an oral progesterone because it can help sleep. Your symptoms will help determine what to take. For example, if your primary symptom is vaginal dryness and painful intercourse, and you don't have hot flashes or other bothersome symptoms, you may benefit from using vaginal estrogen alone. And then route of delivery of the hormones matters. So pills versus patches versus a vaginal ring. And as I mentioned before, there are pros and cons. So some questions to think about. We can save this for the Q&A, but